All right, I think we're going to get started, just so we have as much time as possible for our panel today. Thank you to everyone for joining us today for our webinar, Missing Voices, Listening to People with Lived Experience to Create More Equitable and Effective Pandemic Response. So my name is Beth White, and I am the Research and Evaluation Coordinator for the Office of Health Equity, and as well the coordinator of the Health Equity Impact Assessment, or HEIA, Community of Interest. So a bit about the Health Equity Impact Assessment. It's a practical assessment tool that's used for identifying and improving health equity impacts of different initiatives. So it can help raise awareness about health equity in your organization, as well as spot unintended effects of policies or programs on the health of different populations. So this presentation today is incredibly relevant because throughout the assessment, it's essential to be engaging people with lived experience. It's essential to collaborate and to consult. So the goal of the community of interest then is to increase the application of the HEIA to reduce inequities in access, use, and outcomes of care in Ontario. So we do this through a number of initiatives, including webinars like today. We also have an online course, a newsletter that goes out, and you can find out more by visiting our website with the link at the bottom of the page there, and that will also be shared after the webinar. So we always begin our webinars with a land acknowledgement, and we recognize that this is just a first step towards honoring the original occupants of our place of meeting. So as CAMH is hosting the HEIA Community of Interest webinar, the land acknowledgement is being offered on behalf of CAMH. So at this moment in history, it seems more important than ever to acknowledge people who have come before us and people who we have displaced. I invite you to think about where you are sitting. I'm situated on land that has been occupied by First Nations for millennia. Lands rich in civilization and knowledge of medicine. Lands previously lived upon by the Mississauga of the Credit First Nation. Ontario is now home to a diversity of First Nations, Inuit, and Métis who enrich this province. CAMH is committed to reconciliation and honoring the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our practices. We will create new relationships and partnerships with First Nation, Inuit, and Métis. I also want to think about this virtual space that we are in and recognize who this space excludes, where there are conditions of inequity that make it difficult for some people and groups to join. On that note, I also want to send my sincere gratitude and appreciation to all of our panelists here today. We experienced a few barriers ourselves getting here today, and I just appreciate their patience and perseverance, and it's so important to have your voices here today. I also get the privilege of introducing our panelists as well as our moderator. So Christina is our moderator, and our panelists we have today, Jase, Lisa, and Sandi. So Christina is the engagement coordinator at CAMH's Provincial System Support Program. She's a poet, she's a writer, sound artist, and PhD candidate living in Toronto. Her work incorporates women's lived experience of ECT treatments and their perceptions of its impact on memory. Using survivor testimony, archives, and life writing, alongside theories of ethical listening, her work creates a space for silenced and disenfranchised narratives to speak. Jase Watford is a program assistant at Lakehead University for their Humanities 101 program. He is presently attending Lakehead University and is in his 4th year of pursuing both a bachelor's of philosophy as well as an honors bachelor's in social work. Previously in his life, he's overcome chronic homelessness and addiction. Being a person who lives with mental illness, he spends his time advocating in social navigating for marginalized and vulnerable people. Jase sits on a variety of local, being in Thunder Bay, and provincial working groups. He enjoys using public speaking and stand-up comedy help break stigma and create more awareness in a social context of living with disabilities. Our next panelist is Lisa Fry. She is a quirky and charming mental health advocate with a passion for breaking down the stigma that surrounds mental illness. She identifies as a person with lived experience of mental health struggles and has been involved with community mental health and poverty reduction initiatives for the past decade. She also enjoys comedy, melted cheese, and cats. Our final panelist is Sandi Bell. She is a highly respected expert with over 40 years of experience in the area of social justice, human rights, and equity. She is regularly sought after based on her reputation for knowledge of and sensitivity to Canada's diverse communities and the challenges they face. As president of Empowered Meditation and Restorative Justice Training and Development Firm, she offers a comprehensive range of people-focused expertise in ensuring equality for all. She has served 2 terms as commissioner on the Canadian Human Rights Commission and 6 years as a member of the then Appeals Division of the Immigration and Refugee Board. Sandi was also the chair of the Health Standards Development Committee for AODA in Ontario, as well as a member of the Patient Family Advisory Council. She has volunteered with CAMH on various panels and committees for decades. So thank you all for joining us today. We very much appreciate the expertise you're bringing to this conversation. And at this point, I'm going to pass it on to Christina as she can lead us through a report that the panel worked to develop over the last year.
Thanks so much, Beth, and thank you to all of our panelists here today and to everyone in the audience. I'm so honored to be here to share some of this incredible work that our panel put together. I'm going to give a little bit of an introduction about our process, a little bit about my role in facilitating this process, and some of the main themes that are in the report. And again, I encourage everyone to have a look at it. So before I begin, a little bit about myself and my role here at PSSP. So I'm formerly known as the engagement coordinator, and my role is a role that was specifically for someone with lived experience. So I have lived experience as a service user, and I'm also well entrenched within the psychiatric survivor movement, as well as the Mat of Pride movement. And one of I have the privilege at PSSP to work with the Persons with Lived Experience and Family Advisory Panel. So this is a formal panel that we have that's associated with all of PSSP's work. And it's composed of 13 members from across the province of Ontario. So we have representation from Thunder Bay, Hamilton, London, Sault Ste. Marie, Markdale, Sudbury, Ottawa, Oshawa, North York, Mississauga, Toronto, and the GTA area. And so we have regional representation, and we also took great lengths to recruit panelists from various from both bringing intersectional identities, but also intersectional forms of advocacy work, and also recognizing that they are accountable to the communities that they're representing in this panel. So we have folks who are bringing disability justice work, folks who are working on dismantling anti-Black racism, anti-Indigenous racism. We have folks who are representing the Hearing Voices movement, peer support, service user-led research, the psychiatric survivor movement, folks who are working in harm reduction, addictions medicine, housing rights. That is just to name a few. There is much more. And so in the early days of the pandemic, now it seems like a million years ago, on May 5th, 2020, in the very early days, we came together to discuss how best to center human rights and equity responses to the pandemic by meaningfully involving people with lived experience at all levels of planning, service design, and decision making. And so we had a 2-hour conversation with all of our members, so 13 of our members. And so today we have 3 voices, but please keep in mind that this was a collective effort with our entire panel. And so we came together and we had a series of questions to kind of get at what were some of the biggest barriers that were being exacerbated by the pandemic, how a lot of these inequities were getting worse, and really trying to figure out, I guess, not necessarily solutions, but approaches and perhaps solutions to ensure that justice, dignity, and care would be given to all people. And today, I'm only going to highlight a small sample, but our panelists are going to go deeper into some of these topics, both from their lived experience and also their expertise in the system. So one of the first things is that I encourage everyone to read the report, the experience exchange document, and to share it. I think, you know, it's one thing to be amplifying these voices and listening to it, but I also really stressed that we need to be acting upon them. So I encourage everyone to do that. And so one of the biggest themes was the disconnect between how pandemic planning was going on without including or meaningfully incorporating people's lived and living realities of inequities. And so a lot of the panelists said, like, without this kind of engagement from diverse populations at all levels from across the province, we are really going to be missing the mark. Another big issue was that we also need to apply anti-racism and decolonizing analysis into the planning and research. I'm going to read a quote from the report. It's one thing to be making these decisions in the neutrality and privilege of institutions, and another to be in some of our neighborhoods facing the reality that people are living with. So this is a really powerful statement from one of our panelists that I think really sums up some of the, I guess, frustrations that we have with doing equity work within institutional spaces in the system. So panelists really thought that now is the time to be bringing a diverse range of people with lived experience at all levels to the table. And they were really hoping for kind of a justice-oriented response. So one example was really thinking through new economic paradigms that would foster mutual aid, care, and community capital instead of solely prioritizing private profit. We have not really seen that happen, but I'm going to read another quote. Right now, capitalism is the only priority. It is usually folks who are working class and racialized who are the ones risking their lives. So again, another really powerful quote. And since 2020, we're now in 2021, you know, well into a year of the pandemic, and a lot of these issues that were raised in the report have not been adequately addressed or, you know, attended to. And one of those ongoing issues is triage protocols that we're seeing right now. And there's like huge issues and ethical issues going on with whose lives matter more than others and how doctors are making these decisions. The end of also economic issues for frontline workers and the risk that is going on there. Also issues around digital equity. You know, I think a lot of times there's this myth that, you know, having access to the internet and a laptop means that you can meaningfully access services and all is well. And I think our panelists will go deeper into these issues. So today we have 3 really broad questions that each panelist will kind of take turns leading, and then we will discuss collectively. So the first one is, what are the biggest barriers to accessing health services during the COVID-19 pandemic? The second is, how do you see virtual care barriers intersecting with broader existing issues around the social determinants of health? And third, what changes or suggestions do you have for making virtual care accessible and meets the needs of service users? So I will end there. And that is my very high level broad introduction. And without further ado, we are going to start with the first question. And I believe Jase is leading that. So the first question is, what are the biggest barriers to accessing health services during the COVID-19 pandemic? So I'll let Jase take it away.
Thanks, Dr. Foisey. So barriers, in my experience, I'm in Thunder Bay, there's a lot of overlapping issues. But for me, I think one of the biggest barriers, well, it probably is the biggest barrier, it's food insecurity. You all know that the cost of food's going up, and it's anywhere from like 5% to 25%. In my city, access to food banks was car only for a little while there. Having no access or idea to what the food banks were giving or were they open. Food banks presently at the moment are all the same. So it's Triscuits, rice, lentils, spaghetti sauce, tuna. You know, I get it. It's free, so don't complain, right? But when it's consistently like that and the access isn't there, you know, it affects your mental health. You know, like food affects your mood. And for us, like a lot of individuals, it's hard to reach because Thunder Bay is a city that is built out and not up. So it takes a long time to get places. So if you're a single parent, you've got to leave your kids with somebody or you've got to get on the bus. And the bus is another huge issue here in the city. Transit issues, mobility issues. Just to give you an idea, in my corner, the street that I live on, there's 5 buildings. 3 of them are long care old age homes. One is a mental health apartment, rent geared to income, which is what I live in, and the other is a disability care home. And they were deemed not vital that the bus was stopped. They canceled our route, and we didn't have access to be able to go anywhere. And the majority of us that live in this area live for using the bus. Transit's an issue here with the marginalized and vulnerable people. The other day in my CBC feed, I saw a picture of a transit security worker taking pictures of 2 passed out individuals at the bus shelter in broad daylight, and they were just doing it. I'm not sure for what, but it really hurts people like myself. At the beginning of COVID, the bus was free. So those who couldn't afford using the bus started using it. Then the media then the transit authorities were quoted in the media as people were joyriding, taking it for fun. And I mean, like, talk about feeding a stigma, but I feel guilty and ashamed riding the bus whenever I have to go anywhere. Another big issue is unemployment and income supports. The cost of living is up, and access to any kind of supplies is also a little rough. If you're on Ontario Works, you're on ODSP, that's already not enough before the pandemic. At the beginning of the COVID crisis, the government gave us $100 each. I mean, but I guess every little bit helps. But so for about 4 months, we got an extra $100 to kind of like buffer things. I haven't worked since December. Lockdown keeps the stores closed, so I can't get work at the stores that are closed. And whatever jobs are available have 8 times the application rate. So it goes from 20 to 30 people applying for a job to 140. So I'm not even able to supplement my own income, even though I'm able to work. Another big issue is addiction and relapse support. Opioid deaths are up since the pandemic quite a bit. Relapse is also up because one-on-one supports weren't working at first, and they're still dubious at best. When liquor stores are considered an essential service, you know there's a problem. Thunder Bay has a solvent abuse issue. So when hand sanitizers sold out at the beginning of the pandemic, individuals who used hand sanitizers to manage and cope with life had to find alternative means. And then when backup hand sanitizers were being created, they weren't put through the testing, and they were dangerous to ingest. So we had a lot of issues there. And then finally, I've only got 5 major points. I mean, I could speak forever, but this is suicide support, because everyone's mental health, regardless to who you are, where you sit on the socioeconomic spectrum, your mental health has taken a hit. And I've lost 6 friends to suicide. I have also attempted it myself during the pandemic. It's a very real problem. Mental health supports are sparse, and then many high functioning individuals like myself, we've been fired by counselors because they have to focus on the more higher needs individuals. And I mean, it's pretty straightforward, but when you cut off someone from services like that, the odds are high for a crisis and trauma triggers and putting you into that, you know, high needs area. So I think I've spoken enough to that, and I'll hand it over to our wonderful other panelists.
Thank you so much, Jace. You covered a lot of ground in such a short period of time. I'll open it up to Lisa or Sandi if you want to add anything to that question.
Yeah, absolutely. A number of health services have pivoted to virtual services, obviously because of the pandemic, and some services that were in person are now only virtual. And along with that pivot came this widespread assumption of digital literacy, and that, you know, people would just be able to pivot as fast as, you know, health services were moved online. People would be able to understand all the different platforms and be able to use them in the same way that they were previously able to easily or not so easily go to an in-person appointment. There also has been such a one-size-fits-all approach. If we look at the province's response to mental health services during the pandemic, largely the focus has been on CBT, almost, in my opinion, to the point where if your mental health is suffering during the pandemic, well, if you just do this structured self-guided CBT program, you will be cured. And CBT may or may not work for, you know, mild to moderate depression and anxiety, but that's not the gamut of mental health struggles that people faced before the pandemic and during it. Sandi, did you want to add anything?
Thank you. I can say ditto, ditto, ditto to both of my colleagues, of course. I'm going to pick up on the intersecting disabilities that one may have. We're talking mainly about mental health disabilities, and there can be more than one, as we know. But if one has other disabilities as well, for example, if they need American Sign Language because they are deaf or deafened, that just is not being offered, and that's just it. We don't have it, and it doesn't even sound as if there's any empathy around that. And if you have some complex issues where you need more than one specialist, once again, it is just totally ridiculous. You are not getting the translation that you need. Of course, if English is not your first language, you have that as well. And there seems to be a bit of an hierarchy when you're dealing with mental health services. Mental health is the important thing, and the rest of you just has to hang on. We must be looking at the whole person, be that because one has a physical disability as well as mental illness. As I mentioned, deaf, deafened, or hard of hearing, vision impairments, every one of those has an impact on who we are and how we're going to manage. It must be that whole person way of dealing with us.
Thank you so
That's
much.
it for that.
Thank you so much. And that actually, Sandi, ties into our second question, thinking through intersectionality and really how we might talk about intersectionality, but the doing of that intersectional approach has a ways to go. And yes, so how do you see virtual care barriers intersecting with broader existing issues around the social determinants of health? And I think that's the formal question. And again, you can speak to some of the things you were already speaking to. But I do think, especially with the pivot to virtual services, we've seen a gamut of issues, even including the setup for this very meeting. So I will let you lead that question.
Yes, we won't go there about how easy it is to engage in a virtual meeting. I'm going to ask us all to think about those social determinants of health. There's about 12 of them. Often there are more. But think of the impact of COVID on each of those determinants of health. Have they got better in any way? Absolutely not. And some of the things that were not a major issue before, or just an everyday issue before, have been compounded or have been added to a person's everyday life. Jase mentioned food and food shortage. It is absolutely disgusting in a country such as ours, the number of people who are stressed, who have anxiety, who may not have had those things before COVID because they don't know where their next meal will come from. I heard that $1.04 is what some people are working with per day in order to feed themselves and their family. How can people exist like that? And we touched on the tiny bit of money that has been given to people with disabilities. Single moms, once again, they often had jobs. They often were jobs that were pretty difficult jobs. And now they are either having to go out and do those jobs because they're not going to get any money if they are ill, or if they do catch COVID, or if they can't find someone who can help to educate their children since they're not being educated by the system. Youth, I immediately thought of older adults kind of being in that category myself, but the impact on youth who were out there going to school, having some goals for the future, and now one of the things they're doing is playing on these little thingamajiggies rather than doing their schoolwork. But why not? What do they think of for the future? What are their fears for the future? And so I would be saying that we need to look at those social determinants of health and how there are so many more intersecting issues that have fallen on people. Where are they going to live? Can they pay their rent? Can they pay their mortgage? People with mortgages who don't have that. So the social determinants of health have expanded and have become very, very intersected. And as we start to think about the future, we need to be looking at those social determinants of health in a very different, comprehensive way. And we have to pull some money from those folks who are making 58% more than what they were making previously based on what's going on with COVID and get that money put into our system. I don't know if I've covered enough. I was going to talk about the pros and cons. Do I have time for that?
Yes, you do. Yes, you do, Cindy.
Okay, because a lot of the healthcare folks are telling us to look at the pros and cons. And yes, there are some pros, but I want to just take some of those pros. The pros of not having to travel. Well, certainly for those of us who do have a bus that goes in front of our house, we don't have to travel, but we're already isolated. Isn't going out to a doctor's appointment a way to see people and be out and about? What happens when you don't have the equipment? What if your area doesn't have the bandwidth? So that not traveling is not the pro that it was. And I do have to mention that some healthcare professionals just don't know how to use the Zooms or mixed types of platforms. And then the person using the service, because we're already kind of in that category of maybe not being as swift as the average bear, and I'm saying that somewhat being facetious, but it's not. We are left to feel, oh my goodness, we failed. And there's a mention that the appointments are quicker. Yes, they can be quicker, but there have been times when I have spent an entire afternoon waiting for that 12 o'clock call that just keeps rolling back and back and back. So we have to be looking at whether those pros are really pros. Is it really good to be meeting in your home when there is tension in your home? And can you talk about what's going on when there are issues in your home? Is that a pro? Is it comfortable to be at home? Of course, the virus exposure, that is a pro, but there are so many other ways. Just everything is intersected with everything, and we have to remember that. There just doesn't seem to be a straight line anywhere anymore.
Thank you so much, Cindy. That was so eloquently said. And I really agree that the social determinants of health, we need to expand our definition of them given our current situation now, and really think through how to reduce these barriers, and not to make these assumptions, these easy assumptions of like these pros. And I know Lisa and Jase, I don't know, we have like maybe 1 minute if you guys want to add anything, or we can move on to the next question. Good to move on? Okay. Not all right. So the last question is, what changes or suggestions do you have for making sure that virtual care is accessible and meets the needs of service users, clients? So this question is being led by Lisa, and so I'll let her take over.
Thanks, Christina. I think the first thing that's probably necessary is a talk about money, and money going into the right hands. So, you know, Jase touched on income security and how the additional COVID benefit for Ontario Works and ODSP recipients was just cut in July. So did the pandemic stop in July because suddenly people don't need that benefit anymore? So another thing that I want to mention is the disparity between social assistance. So the federal government put out CERB and CRB and basically determined that people need about $2,000 a month to live on during the pandemic, yet a single person on Ontario Works can get a maximum of $733. I don't know how to live on $733. I don't think it's possible, and you certainly can't live a healthy, meaningful life. ODSP is, you know, give or take $1,200 to $1,400 a month. Social assistance and disability assistance rates need to match exactly what the federal government suggested that people who are out of work need during the pandemic. There needs to be funding for individuals and families to obtain devices and reliable connections, so some sort of digital access benefit. But in proposing a digital access benefit, there also needs to be an option for folks to who have barriers to getting that device once they have the money or setting up that internet connection. There needs to be another flexible option where the device is purchased for the person. I work with clients with severe mental illness and addictions, and giving a benefit of $500 may be a trigger for their substance use, and they would be much happier to be given a device and have the internet already set up for them. There are other medical barriers that people might have to having money in their bank account and actually being able to get the device. So there needs to be flexible options with the benefits that are provided. There also, I think, needs to be funding for smaller grassroots organizations. We've talked a lot in the panel about a number of small organizations that are doing service provision and filling in the gaps for people incredibly well, and they're doing it better than larger organizations like Central Lynn and the Ministry of Health. So those organizations can set the best practices, but they need the financial support to expand their services. One organization that I think is incredible is in Toronto. It's called Sound Times, and they set up little cubbies where people could come in and utilize phone, internet, fax, get one-on-one support, and actually have that safe space to access maybe health services or mental health services. You know, when we think about folks living in congregate settings or somebody who lives at home with someone who is abusive, you might have access to digital devices and tools, but is that a safe place for you to go online and complete your health or mental health appointment? And is that a private and confidential setting for you to do that? Privacy and confidentiality when we go to our doctor's office is really inherent in the setting, in that physical space. So there's incredible organizations like Sound Times that are problem solving, but they need money and they need more awareness. I also think that changes to legislation and public policy need to happen in terms of, if we've decided that, you know, we live in a country where healthcare is universal, and it's a right that we have as a person. If healthcare has moved virtually, then digital access should be a human right, and connectivity, should be a human right. And there needs to be language in public policy that speaks to that, perhaps as, you know, a internet and a device as an assisted device necessary for healthcare and wellness. And the last thing that I really want to hit home is in a lot of spaces where we collaborate and discuss digital options and how to make them better, we forget that digital and virtual healthcare is just not going to work for everybody. And we need to continue to provide in-person services. And we need to make these in-person services an option for people that have complex barriers and, you know, different kinds of accommodations are not going to work. There's also a lot to be said about sort of the human touch, things that are lost on a webcam. And a lot of our panel members especially spoke in terms of mental health service provision just not being the same when you're on the video or the phone. And I would imagine that would extend to healthcare as well. There's such a burden on the client in virtual healthcare to be able to articulate and communicate exactly what's going on. Whereas in person, the health provider has a lot more that they're using to see what's going on. And there's less of a burden on the client to, you know, express it properly over video or phone. There also, we need to consider, you know, people who, for example, are on the autism spectrum or are having hearing voices or living with parallel realities. Imagine the overstimulation of constantly being on a screen and what a barrier that would be to accessing healthcare. So in-person services need to remain, and it can't just be through the ERs. Thanks.
Thank you so much, Lisa. Very comprehensive response. I'm just going to note we have 4 minutes left, but I want to give a chance for both Sandi and Jase to respond. So whoever wants to go first to add to the incredible list of recommendations by Lisa.
Thank you. That was very comprehensive. We all have to remember that when we're overwhelmed, and I'm really, really understanding overwhelmed, we are less likely to reach out for help. So let's the healthcare system be reaching to help folks. But we can extend the hours of this virtual care stuff. It doesn't have to be 9 to 5 anymore. And what about a drop-in service? Maybe it's not safe for you to talk about something at a certain time of day, but it may be safe at another time of day when someone has left the room. When we are giving out devices, and I know that they are giving out some devices, make sure they're the right devices that do the things that are needed, because I have seen people get devices that are really cool and do all kinds of things, but they won't connect them to their healthcare services. I spoke before about ASL language services. We must have those. Sound Times has always been ahead of the pack. What about centralized hubs that are put out there across the province? And thank you for mentioning human rights. The Ontario Human Rights Commission requested that the province take a human rights approach to COVID. It hasn't started yet. Let us please keep telling them to do so. I think that's good enough.
Thank you so much.
We've been very comprehensive.
Jase, I want to give you the opportunity to weigh in and to add.
I don't know. Devore, what Matei once said, this is a system designed to add stress on people who are already stressed. So piggybacking on what Lisa and Sandi was saying, we need to find a way to meet a client where they're at, especially in the pandemic. It's an obstacle when the workers are restricted. The need for more holistic measures is important. We need to be more upstream thinkers. Throwing money at the problem is not the answer. So I don't know how many agencies are providing technology, but I do know of some people who have 2, 3, and 4 pieces of technology who have then flipped it for money to go to the grocery store. I think if we're really looking at change that might mitigate barriers, vote. Honest to God, I don't like Doug Ford is not the capable man that needs to lead this charge. Clearly a buck of beer platform worked for him, but it's not working for us at the moment. And life skills, you know, like childhood neglect turns into adulthood neglect. So life skills training at a young age, and then life skills workshops for adults, to give us the tools that we need to be able to work as best as we can independently and thus build our own capacity. So thanks for the opportunity to talk.
Thank you so much, Sandi, Lisa, and Jace, for your incredible analysis and contributions today. I think now I have to hand it over to Beth and Michael.
Beth, you're muted. Sorry, thanks.
I was double muted on that one. Someone had to do it on this call. I just want to echo what Christina has been saying. Thank you so much to each panelist for providing this really important insight, not only discussing what challenges are, but also providing solutions as well, which is so wonderful to hear. We have had a number of questions that have come in, so I'm going to dive into that. And just a reminder to everyone to send your questions to either all panelists or to everyone. If you send your questions to all attendees, unfortunately, once again, we're not going to be able to see that and get to your question. So to start us off, a question that we received is how to best engage with people with lived experience during the pandemic. So another way that question was asked is, how can we reach out to the community, to members that there are not already existing lines of communications to make sure that they're engaged? So I'm not sure, maybe Christina, do you want to? Oh,
I see Sandy's hand up. So.
Actually, this was one of the questions that popped in my mind as soon as I started reading all of this. We need to be going out to community agencies, the broad range of community agencies, and asking them to allow us to speak with the people who they provide service to. All of us here today are privileged in one way or another, and therefore we get this opportunity, but we must get to the people on the streets.
Absolutely. Sorry, I just want to add one more thing to that. I think this is something that came up in our discussion, if you all remember, Lisa, Jason, and Sandi. And I remember somebody talking about doing more outreach that is even beyond the community organizations. So looking at places where people are already existing, right? So we have encampments right now in Toronto where there is a lot going on and a lot of need. And so really trying to figure out how best to reach out to those who are not making it through the door or through the virtual space of organizations as well. So Jace, I think you had a...
Right, like just to kind of go with echo what Sandi was saying in regard to like hard to reach clients. That's a serious issue, especially in my community. Just getting them off the street and into shelter to access a social navigator is a challenge. There's a lack of safe spaces for the homeless. It used to be malls, used to be libraries. We've got a warming center and we've got a care bus, but people who are in the throes of addiction and are in full-on crisis, they've got different needs and different priorities. So the pandemic to them is not the first thing on their list. So we need to find a way, because they were hard to reach pre-pandemic and now they're even harder to reach. So I think that's super important to look at.
Perfect, thank you. My next question, or the next question that's come in, is looking at, in a similar way, looking at how voices are recruited to be a part of this panel. So how to ensure that when you're recruiting people with lived experience, how can it be a positive experience? So how are people reimbursed for their time and components like that?
Right. So every member here today is a core member of our advisory panel, and they receive payment compensation for their time. So there's preparation, they're paid for their preparation. I mean, they can speak to this, but and for the actual delivery of this this panel. And it was a voluntary submission. So I sent out a request to the entire panel to see who was interested in participating today. And these are the three folks that, you know, wrote back to me. And so we've been working with them. Again, our panel is not representative of, you know, the entire gamut of the diversity of Ontario. But I think each member here today is connected with and accountable to communities and to organizations and to other advocacy groups. And they perhaps want to speak more to that. But yes, everybody here is compensated for their time equitably and informed of the goals of yeah, I mean, I can talk for you just about engagement, but I won't take up more space.
I guess just to add to that question for the panelists, beyond just compensation, and I realized that there was quite a bit of prep time that was put into this, so very appreciative of that. When you're involved in panels like this, or other work that you're doing, what helps ensure that it's a positive experience for you? Yep, Sandi?
I would say the opportunity to work with the folks that are around the table, the 13 of us, we are diverse. We are so very skilled and knowledgeable, and we treat each other with respect. So it's when we meet face to face, it's lovely to go back to the meeting, and the staff is amazing. And so yes, this is not the first of the CAMH committees I've been on. I've been treated well, and I've had really great people to work with and learn from.
I just wanted to add, in terms of being on panels like this, and my experience in similar communities where there's engagement with people with lived experience, it has to be a meaningful engagement. And the dark side of that is tokenism. So there is more move from large healthcare organizations, systems to include the voices of people with lived experience. But when that doesn't lead to any kind of meaningful change, when, you know, voices are heard, but they're not actually incorporated, when we're not, for example, at the planning stages of COVID response, the design, the implementation of service provision, that's when for me, it starts to feel like tokenism. And I also want to say that even being on these panels is a privilege for me. And I always try to think about, you know, I'm able to communicate in a certain way and articulate myself in a certain way. And what I think that means is I present as well enough in these spaces to be accepted in these spaces. And there are folks who have lived experience that are not able to present in the same way, and their voices, you know, aren't representative on many panels and engagement and things like that. So we always need to be mindful, even when people with lived experience are invited into these spaces, who isn't here because they may not, because they live in an encampment or because they are incarcerated, who's not in these spaces even when there is meaningful engagement. We need to think about that.
Oh, yep, Sandi, did you want to add something else?
Yes. Yes, if I might. And this is just a personal thing that I do, because I know that everybody isn't at the table. If an issue comes up without breaking any confidentiality rules, I will talk to folks who I know aren't at the table and pick their brains. And so then I bring not only my knowledge, but some that I've picked from other people. But I'm always very careful not to infringe our confidentiality.
Perfect.
Perfect.
Thank you.
Thank you.
Oh, there you go. Well, I think that's all the time that we have today. I apologize if we weren't able to get to your questions. There's a number of them here that we can definitely connect with later on if you want to send an email to healthequity@camh.ca. That email, along with the information from this webinar, will be provided to you after the webinar. I'd like to say thank you once again to our panelists for such insightful information, and hopefully it truly will help inform moving forward a more equitable and efficient pandemic response. I want to also mention, if you have the chance to take just a few moments once this webinar closes, you'll be prompted with an external link to fill out a survey and evaluation, just to let us know how you found today's webinar, as well as help inform future webinars. So once again, thank you so much to everyone and have a wonderful day.